So good afternoon, ladies and gentlemen. Thank you for coming to this PCR-sponsored session on TAVI. This session is sponsored by VitaFlow, which is the TAVI device from Microport, a Chinese company who are very involved in cardiovascular devices, both in the Asia-Pacific region and here in the EU. We're going to try and get you guys interactive with us, and so you know what these are. These are catch boxes, and so you have to keep the hands ready because they could be thrown at you at any point. So, for example, Tad, there you go, throw it back. We test your skills, of course, here. There you go. Anyone down the back want a long one?
Yeah, go for it.
Yeah? Vicky, what do you think? Come on. You get an extra 10 points if you manage to dive and catch
Finally,
it.
the English have a good goalie. Yeah, that's a long time.
Anyone here from Hungary, by the way?
Hungary?
No. Just wanted to be. Ireland played Hungary in soccer last night, and we beat them 3-2 in the 96th minute to qualify for the World Cup. So
you're also
if there's any Hungarians here, I'm sorry. What's that?
You're also good friends with Cristiano Ronaldo.
Yeah. Cristiano doesn't like the Irish very much. So I'm joined by Ollie de Backer, Angela McInerney, who works with me in Galway, Dr. Liu Jianfang with us from China to share his experience. And Marco De Carlo was supposed to be here, but seems to have disappeared momentarily, but we'll manage. What I wanted to do is take you all through the Microport system, because I'm not sure that this device will be familiar to all of you. But it's a device that has been CE marked in the last year for high-risk patients for TAVI, and has some unique features that I think really can be impactful for our patients. So why don't we just have a little chat about the device, and we can see where those features might fit into your clinical practice. So this is the broad outline of the device. It's a hybrid density where there are low density cells at the top of the device and much higher density cells at the bottom of the device. This renders the top portion of the valve to be quite flexible, improves delivery, improves coaxiality. And then the bottom portion of the valve, where you really have quite high density of nitinol, you have high radial force. And that high radial force is really quite important when you consider heavily calcified patients with bicuspid aortic valve disease, for example, and hence paravalvular leak, residual gradients are very uncommon entities with this particular self-expanding valve. Those large cells, of course, provide excellent coronary access. The leaflets themselves are superannular. They start 10 millimeters above the bottom of the frame. It's a bovine pericardial valve. That typically gives, as I mentioned, low gradients, good EOA, and there's a high hoop strength in that center area that provides stability for the leaflets, so that compression of the bottom of the frame does not always translate to deformation of the leaflets in the mid portion of the frame. It's tubular shaped, and I'll show you the sizing, but ultimately you have a millimeter or two from the bottom of the frame where it comes in, and thus is attempting to preserve coronary access in those patients that have shallow sinuses, and the skirt is really best in class. As I mentioned, that PET double layer skirt that fills up with blood rarely leaves your patient with paravalvular leak. In terms of the sizing matrix, there are 4 sizes of this valve: 21, 24, 27, and 30. And the one thing I will get you to notice is that, for example, the 21 millimeter valve is 22 at the bottom, and the 30 millimeter valve, for example, is 32 at the bottom. And so even though it says 30, you can treat annuluses quite comfortably up to 29. One of the most innovative things I think about this valve is this delivery system, and I'm not going to say too much on it because Ole is going to tell us about the next generation of delivery system that is going to come. But this is really the only commercially available device where there's a motorized delivery. Initially, I thought that might be a little bit of a gimmick, but in fact, what it allows you to do is 2 things. First of all, the device is very, very stable once you position it in the LVOT. It really doesn't move cranial or caudal a whole lot. And second, it allows you as a single operator to deploy the valve and to keep your hand on the wire. So you can deliver this as a single operator procedure. I'm not suggesting that we get rid of the second and third operators, but of course, as we become busier, as we have to run more TAVI lists, being able to do it as a single person, or indeed in challenging cases where you really need to control the depth of the valve quite accurately, this delivery system can actually be quite useful. The one piece of evidence that the company have, and it's really good quality evidence with this was a trial that was run on 120 patients treated in China. Almost half of the patients treated with this device were severely calcified bicuspid disease. The other half were tricuspid disease. But we now have 9-year follow-up on these patients. The average age, as you see, is 77. And it's remarkable that out to 9 years, we still have 55% of those patients who are still alive with a mean age of 77. The encouraging information that is from a dedicated core laboratory is that the mean gradients and the effective orifice area in this small cohort of patients remain very stable out to 9 years, and that is irrespective of whether these are bicuspid or tricuspid native annuli. So the idea of this session is that we share some cases, we share some experience with you. But maybe, Angela, before I hand over to you to share with us your case, what are the features of this device that you like, and where does it fit into your day-to-day clinical practice now that it's available in Europe?
Yeah, absolutely. So, as you say quite rightly, we work together in Galway. We have this device available to us in Galway, and we've used it in a number of patients now. And I suppose, when you are choosing what device to implant for your patients, there's many patients where they're suitable for lots of different devices. But then there are certain cohorts of patients where they have specific criteria or specific things that you might find on their pre-planning CT that might push you towards one device or other. And we quite like this device, for example, for the heavily calcified annuluses, because it has, as Darren already explained, that radial force at the bottom and the flexibility up at the top. We very much like the fact that you have differences in the cell density from the bottom to the top, and this really is useful for coronary reaccess. So for patients that you think might be at risk of coronary occlusion, for example, or even your younger cohort of patients who we need to think about lifelong management and maybe reaccessing their coronaries. So they're kind of two main patients that we would consider. And of course, when we talk about those heavily calcified annuli, we're kind of really thinking about our bicuspid cohort as well. And they do actually, there is quite nice data from MicroPort regarding their use of this valve in bicuspid aortic stenosis.
Okay. Before moving on to Angela's case, has anyone got any questions about the platform itself? Any issues about the delivery system or anything you'd like to know before we move on to some cases, or will we just get going? Okay, maybe we'll just get going. So, Angela, let me hand this over to you and tell us about your case. Great.
So just in terms of, do people have experience with this valve? Has anybody actually implanted this valve in the audience? Yeah, a few people. So that would be really good that we might be able to share some of other people's experience as well. And so this is a procedure that Darren and I did. I'm very glad to hear that Darren doesn't want to get rid of me as second operator, despite this being an easy to deploy valve as a single operator, which hopefully we'll demonstrate during this presentation as well. So these are my disclosures. So we're going to start off with our patient. This is a 78-year-old gentleman, very typical TAVI patient that I'm sure most of you will be familiar with. He has a number of cardiovascular risk factors, including type 2 diabetes. He has CKD, hypertension, and dyslipidemia. He's actually been coming to our clinic for a while under surveillance for aortic stenosis, but on his last review, he told us that he was now getting breathless on exertion. He's NYHA class 3, and when we checked his NT-proBNP, it was elevated. His ECG, as you caught a glimpse of there, just showed some sinus rhythm with no conduction abnormalities, normal PR, normal QRS. And his echo showed a severely calcified aortic valve with a mean transvalvular gradient of 48 millimeters of mercury and an aortic valve area of less than 1. So very clearly severe high gradient aortic stenosis of a tri-leaflet valve. So this gentleman was discussed in our heart team meeting, 78 years of age. We previously would have discussed anyone under 80, and the decision was that he should go forward for TAVI, which I think was very clear, and we proceeded with some further workup, specifically his pre-procedural CT for TAVI planning. So you can see here that as we roll through the valve, which hopefully you can see up there, that it's a sort of moderately calcified valve. This has an area of 400 millimeters squared and a perimeter of 70 millimeters, so not a very small valve, a sort of moderate sized valve. The sinuses are generous at 26 millimeters. As you can see, there's moderate calcification. The coronaries are at a good height. Right coronary is very high at 20, left coronary is almost 12. And then we always use our CT scan to predict our angles for implantation as well. So I've just given you both the coplanar and the cusp overlap, but you'll see that we implant this valve in cusp overlap as we show you in our example. But just for this patient, a coplanar angle would have been LAO 13, cranial 5, and cusp overlap RAO 8, caudal 18. We also, of course, use our pre-planning CT to look at his femoral axis. You can see that there's some mild tortuosity in his iliacs, and particularly his aorto-iliac junction. There's some calcification. However, there's no calcification at the actual site of puncture in the common femoral artery, so we weren't anticipating that we would have any difficulties here. And he has a 7 millimeter diameter of his common femoral.
Angela, Marco's got a question for you.
Yeah.
I would like to ask you, how many of you would be scared about coronary access in a patient like that? Can you go back a couple of slides? With this diameter of the sinuses of Valsalva and with this height of the coronary arteries, would you be scared of a system that does not guarantee perfect commissural alignment, or would you consider it a contraindication?
So that's a nice question. We have a left coronary at 12 millimeters. Right coronary is pretty high. I think we could all probably be safe to say we're not worried about the right coronary. The sinuses are 26 millimeters. I haven't quite shown you what size valve we would be choosing here yet. But is there anyone concerned about my left coronary that we could occlude it during the procedure?
So anyone want to make a comment on the coronaries or a risk of coronary occlusion here? Any brave souls out there? No? Yeah, I mean, the sinuses essentially are, where are they?
Yeah, 27 average.
27.
Yeah.
And we're probably in the region of a 24 valve. And the 24 valve comes in a millimeter, so it's probably 23 at the level of the, so we should have enough. The other thing, Angela, I wonder, can we go back one and then come forward again?
Yeah.
One of the other sessions here earlier this morning spoke about one of the other ways to look at risk of coronary occlusion is to look at the leaflets, and is there leaflet tissue in front of the left main? So if we go forward one more, just that bottom left-hand corner, as the left main comes in, just there's pretty much no leaflet tissue in front of it. So the leaflets might just get there, but with reasonable sized sinuses, Marco, I think we're okay. This is probably an anatomy that can take any valve, right? Yes. I think we can get a good result with any prosthesis here. I think it's important to say that there's no, in this particular case, there's no real challenge, but I suppose in terms of, that's to me a moderate plus calcified valve, and so let's see what you did.
Yeah. So, I mean, it's a really good point, but if we recall our measurements here for this aortic annulus, we have a perimeter of 71, area of 400, and an average diameter of 22.6. So this patient actually nicely fits in to a VitaFlow Liberty 24 millimeter self-expanding valve. So that was our plan for this patient. So just in terms of the procedural plan, which you'll see that we followed in the video, so we were going to use right femoral artery as our therapeutic access to pass the valve. We obviously were going to do ultrasound guided access, which is our normal workflow. We pre-close with one ProGlide, and then afterwards we usually use 1/8 French angio seal if we've had no complications. Non-therapeutic access for a pigtail would be the left radial. The procedure was to be performed under local anaesthesia. We usually pace on the wire for self-expanding valves, and that's what we did in this case. We pre-dilated using a 22 millimeter balloon, which is the average diameter of this patient's annulus. So we knew that we would be safe using a 22 millimeter balloon in respect of the anatomy that we were dealing with. And then the plan was to implant a VitaFlow Liberty 24 millimeter self-expanding valve. So I think we can move to the case. So this is our case. I think we'll just let it run through, Darren.
The hospital, I'm Darren Milet. I'm joined by my colleague Angela McInerney, and on the table with us today to demonstrate the features of the MicroPort CardioFlow VitaFlow Liberty valve is Paolo as our fellow. Our patient today, as you've seen, 78-year-old, some tortuosity in the iliacs and the aorta. Moderately to severely calcified aortic valve, tricuspid, and we've elected for a size 24 millimeter device. Angela, tell us, where have you got to so far?
Okay, so we've already done our vascular access, Darren, and we've used our standard approach to transfemoral TAVI. This patient is suitable for a transfemoral TAVI, despite the fact that there is some tortuosity in the iliacs. So as you can see, we have a large gore sheath, an 18 French sheath in the right femoral artery. We did ultrasound guided access for this femoral sheath, and we pre-closed with one ProGlide, which is our normal pre-closure approach, and at the end of the procedure we will close with this ProGlide plus one angio seal. We also have left femoral venous access with a 7 French sheath. We usually pace on the wire here, Darren, so you can see that we're already set up for pacing here. We also use the side arm of this sheath to give drugs, which the nurses can do. And then also we have left radial arterial access with a 6 French sheath for our pigtail, so that we can do aortograms during the procedure. Okay, pacing on. Okay, and lead balloon up.
There's the balloon up.
Balloon down.
The 22 millimeter.
Pacing off, and we'll store that fluoro.
So I suppose first we have an inline sheath. The capsule is a little bit flexible. It's hydrophilic. The nose cone, nice and soft on atraumatic. It's a 24 millimeter bovine pericardial valve with a PET skirt, high radial force. And what we see on the catheter here, 3 buttons: on to turn the system on, and then retrieve and deploy. We tend to leave the system off until we're at the point in the aorta where we're going to release the valve. There is a manual wheel here in case we have a problem with the battery. We haven't had such an occurrence to date.
Okay, you can see it's traveling nicely.
And you can see there's some flexion in the system there as well. Wonderful, nicely done. Okay, ready for an angio?
Yes, and angio.
Okay, so you see very nicely our cusp, pigtails in the right spot. It's a good marker. And our device is right at the bottom, so we can turn the system on. I'll let you grab the wire, and we can go ahead and deploy now. And Paolo's ready to give us a few little tests should we need it. So nice and steady. Device just coming out now, just exiting the system.
Little test maybe, Paolo.
And Suresh, you're ready to pace for us. Little test again, Paolo. Yeah. What do you think, Angela?
I think I like it actually. Yeah. Do you? And
maybe
you,
a
Darren?
tiny bit higher.
Small bit higher, so I'll
Test
just
there, Paolo.
manipulate the wire for that.
Yeah,
Yeah,
that's pretty good.
I think that's pretty good.
So let's go pacing on now, Suresh, please. So we rapid pace to try and keep the device in the right spot. Okay, and pacing off, please. Okay, so just underneath. Well, we've got lots of parallax, so let's
Yes,
keep
we
the
do.
call now, and we'll just roll straight LAO under fluoro, Angela. Oh, it's perfect, huh?
Yeah, I really
Doesn't
like
come
that,
better than
Darren.
There we go. That's great.
Great.
So blood pressure's 100, so Angela, a few fluoro now. We'll just go nice and slowly. and you keep a little bit of forward pressure on that system. Again, this can be done pretty much as a single operator. There's one of the tabs off, two still attached. Okay, so nice high implant I see, no aortic incompetence.
No.
I'm looking at our QRS complex, it looks narrow as it was at the start. I see both of our coronaries open. And actually in this view, you know, maybe 15 degrees out of commissural alignment, luckily.
Yeah.
Not by design, but...
Not by design yet for this device.
Yeah. Okay. Nicely just underneath the inferior epigastric duct, neck and hernia. But we see no bleeding, which is great. So we'll take this out and finish up there.
Yeah.
But Angela, maybe to summarize the case, severely calcified tricuspid aortic valve stenosis, very typical transfemoral access, pacing on the wire, radial secondary access, pre-dilated with an 18 millimeter new med, a very straightforward implant of a 24 VitaFlow Liberty. A little bit I suppose, failure to release from one of the tabs on that device. It happens with all self-expanding devices from time to time, but no issues with it. And our I suppose our post-implant looks gorgeous with no PVL, no residual gradient.
Yeah, so I think we've had a great result for this patient.
Yeah, exactly. So nice case, well done.
Yeah.
We look forward to seeing you all in London, and thank you to MicroPort for allowing us to film this case for you. So from Lab 2 in Galway University Hospital, we'll see you later. So welcome to Cath Lab 2 at Galway University Hospital. So
we won't watch it twice.
I did notice that I had a little spot of blood on my forehead there, Angela, so maybe I do need a second operator, huh? So a very typical VitaFlow case. As you saw, the system goes in very easily. It flexes around the arch, it comes around, and much like most self-expanding valves, we go to that RAO caudal, that cusp overlap view, we deploy the valve. I don't know, Ole, I know you do things a little bit different in your lab. We like to rapid pace once the valve is a little bit expanded, almost like a self-expanding valve. We find that it keeps the valve in the right space. Does anyone else do that, or how do you deploy it? Marco, how do you do this? Tell us.
Thanks. I got it. I actually want to congratulate you on this very nice case. I do the same setup. I usually have I have the same setup. I think that this case nicely demonstrates two things. The first one is if you predilate rather aggressively, let's say, you caused quite relevant aortic regurgitation. So how many of you here would have chosen a smaller balloon as a predilatation? Just raise your hands.
Okay.
So the majority would have used a 22 millimeter balloon. Raise your hands if you would have chosen the 22 millimeter. So many people are shy; they don't want to say. But in this case, if you predilate adequately, you can have a very stable implantation. You saw on the first attempt, I guess there was no cut and paste in the video. So on the first attempt, the valve was extremely stable. This is very nice and very peculiar to this kind of platform. And also the expansion looked very nice. The stent frame looked very nice, nicely expanded in the cusp overlap view. So where you usually expect to be a little more constrained. So I think this case nicely shows that this combination of this high radial force prosthesis with inadequate predilatation allows you to get a very nice expansion of the valve without post-dilatation. So in my experience, actually, even in very calcified cases, even in bicuspid cases, I was able not to post-dilate because there was very low gradient. But I don't know how many of you do post-dilate routinely, a self-expanding valve? Very few, you are alone.
Yeah.
Does anybody want to say something about why you don't post-dilate? I saw you were a little bit... Yes.
But I was struggling with the definition of routinely. I mean, we do that quite often, but only if it's needed. So routine is not if it's needed. Sorry?
The threshold for doing post-dilatation.
Yeah, depends on the valves looks like and what the gradients are. So yeah, we do it. We have the echo. By the way, I'm a cardiosurgeon, so we do it together with the.
It's not your fault. It's not your fault. And you are welcome here, my friend.
We see things differently, so that's what I'm trying to say. But yeah, we have the echo machine and echocardiologist do that.
On echo and
So
on
routinely for us is we do it routinely according to what.
Yeah,
but it is an interesting question, right? The whole concept of optimization of our stent frames. We've seen recently, for example, with the double tap study, which was published in the last episode or edition of your intervention, that even with balloon expandable valve, if you implant the valve and you have a perfect result, no PVL, no gradient, and you then do a post-dilatation with the same balloon, the same volume, you don't change the PVL, you don't change the gradient, but you do get an extra 10% in terms of valve area if you do a post-implant CT. Is that relevant in terms of the durability of the leaflets? Does it stop focal malexpansion, which is what they found in the Accurate Neo trial, that's the cause, they believe, of all the valve failures and strokes that they had? Is that something that we need to think about? On the other hand, there might be a cost for doing a post-dilatation. You know, we imprint the frame of the valve on the leaflets. The answer is we don't know. The difficulty with assessing malexpansion of a valve is that it's challenging in the cath lab. We implant an RAO caudal, you can roll your C-arm LAO, you can come up LAO cranial to a kind of an isolated left coronary cusp view. But once you get to the extremes of that S-curve, it can be quite difficult to understand what you're looking at. So in our practice, for self-expanding valves, we would probably post-dilate maybe 80% of valves, irrespective of gradient and PVL. Is that the right thing to do? We don't know. One of the nice features of this valve, and we didn't post-dilate this one, is because, as you said, it's well expanded. It's got high radial force. And one thing that I've learned about this valve is that if you've got a PVL, there's something wrong. Because you normally get 0 PVL with this valve. It's almost like a Sapien valve in that it's really punchy, you've got a great skirt, and so if you've got PVL, I would always post-dilate this particular system. Yeah.
If I have the microphone, I will take advantage of it.
Of course.
Very nice results, so you didn't need it, but at the beginning I had the impression that your system was coming quite vertically, if you, for the annulus plane of the valve. And what I usually see to my, that my cardiologist friends do is to rotate the system anti-clockwise so that the curvature of the system will come a little bit more on the same axis of the annulus plane. So you didn't need it? Is it possible with this system?
Yeah, it very much depends on the design of the shaft, right? So for example, with Medtronic, the design is one stiff bar that runs the length of the system. With, for example, the MicroPort system, it's almost like a shark skin. It's a helical shaft. So you can get movement in the system. You see as it comes around the arch, it does deflect. Even the actual capsule can deflect a little bit. And so very often, pushing on the wire, trying to get the system onto the outer curvature, you can end up with that. But ultimately, all long valves will come down a little bit vertically. You can play with the wire, you can try and manipulate to get it on the outer curve. But with most of these systems, long systems that don't steer, you end up a little bit shallow on the right, a bit lower on the left in most situations. But MicroPort might have a solution for that coming up, so let's hold that. Any other questions? Yeah. You ready for a long one?
Oh, come on.
Oh, it's a bad one. I'm gonna take the hit for that one. It was great.
Close.
Sorry. Yeah.
You mentioned during the presentation that the system has an inline sheath. Although I noticed that you put an 18 French sheath as well.
Yep.
So does it require an extra sheath?
No.
And is it 18 French for each size, or it's smaller for the smaller and bigger for the bigger?
Yeah, that's a really good question. So we initially put a sheath just so that we could pre-dilate, so we obviously need a sheath for pre-dilatation.
But you don't need an 18 French sheath for pre-dilatation.
Yeah, that's true.
So
I guess we just...
The device ultimately it's between 19 and 16 outer diameter sheath. That's what the nose cone of the delivery system is. And so it's a little bit larger, for example, than the Medtronic, which is 14 French, than the Abbott, which is 15 French. So yes, you are using a bigger sheath for this particular device. It is perhaps one of the weaknesses of the device that you need to have femorals that are able to be 6 millimeters. Can you go 5.2, 5.3? I think it depends on the patient. But yes, you're right. The sheath is a little bit bigger than other self-expanding devices. Yeah.
Maybe
other questions?
If I may comment on what you demonstrated nicely in the live case is the precision and the stability, yes, and that's a little bit the thing. So if you compare balloon expandable, self-expanding, balloon expandable has a very good reputation because of the stability and the precision you can do that case with, yes. Whereas a self-expanding, it's always a little bit more difficult. I mean, as an operator, you have to take a little bit. The thing with this device, what I feel, honestly, as an operator, there are 3 components that makes this valve super stable and predictable for me. There's one, you have that motorized handle, which turns out to be some really great feature to be very precise, because you have less manipulation and movement with that catheter, so you can just basically hold it and go motorized there. And then the other 2 components you stressed already, the inflow, the distribution of the forces in that stent frame is great. You have high forces where you have to have high forces, there where the calcified leaflets are. And then you have much softer forces on the outflow, and that's actually a great distribution of the forces. That's why this valve, as soon as it's open, and then with the final release, I've never seen this valve moving a lot like up or down. It's rock stable. So that's a good distribution of the forces. And the third thing is, we didn't discuss, but this catheter, the delivery system, is a little stiffer. It's a little stiffer than the Evolut, or for sure than the Navitor delivery system, for example, if I can compare. But in the beginning you think, stiffer, it's maybe worse. But on the other hand, the little more stiffness in the catheter makes this entire deployment also just more stable. So it works advantages. Yes, it has advantages. So I think these 3 things, that the valve on the inflow has most stent frame, has more radial force on the inflow, makes it very stable. I dare to implant this valve systematically, routinely. I don't always succeed, on 1 millimeter. Yes, and do that once with an Evolut or with an Navitor. Good luck with that. That's not possible. So this valve you can do repeatedly, very stable, very precise implants. That's what I like about it as an implanter.
It doesn't move a whole lot, and I think the reason it doesn't move, Ole, is because, as you say, down here you've got a lot of radial force, but up here it's quite flexible. And so unlike many other systems that are going to sit over here and ultimately going to have to move in this direction.
They always tilt then.
It's already tilted. You already have the tilt because the system is flexible at the top of it, and therefore it tends to centralize, the delivery catheter tends to centralize, so when you release it, it doesn't move. Whereas with other systems, if it's over on the greater curvature, when you release it, it has to move over towards the center.
And it proves that if you know this device, there's a small learning curve, but if you know this device well, you can actually implant this almost like a balloon expandable. I mean, typically it's a single shot. I mean, it's very rare that I reposition this valve, to be honest. It's great that feature is there, but it's not like with other self-expanding devices that in 2/3 of your cases you reposition. No, it's not. I mean, it's like the precision and the predictability of feel like a balloon expandable. So that's what I love. Yeah.
It goes well.
So we have a question over there?
Yeah, sure.
Yeah.
And sorry, you had a question as well, please.
It's about the recaps or retrieval of the valve.
Sorry, just hold up a little closer.
Hello, can you hear me now? Yes.
Yep.
Sorry.
Yeah.
I wanted to ask you about the recapture. Can we do recapture, or
of
course. How many? And then in case, if we have to take out the valve completely, can we take it out?
Yeah. So it's recapturable, 75%. So it's pretty much the same as the other systems where there's a black marker. You bring your marker band back to the black marker, which is about 75% deployment. You don't like it, you can then recapture it. You get 3 recaptures before it's recommended you remove it and use a different device. If you don't like it and you want to take it out, you can fully recapture it and remove it inside its delivery capsule. So pretty much the same as the other self-expanding devices in that vein.
We have another
My question is along the exact same lines. Can you just elaborate a little bit on the specific control on the motorized handle? Is it just forward or back? Are there hard stops? Is it visual? How are you determining where you are?
So in fact, when Microport started with this, we didn't really know how quickly or how slowly you wanted to deploy it. So there were 2 speeds. There was go fast and go slow. And honestly, I don't know which was right. So I think they settled somewhere in the middle. And so in the same way as some cases you really want to go fast, you don't have that opportunity. It's 1 speed, but because it doesn't move, you don't need to manipulate it so much, to be honest. So you got, in terms of the handle, you've got forward and back. That's it. 1 speed. It's the same.
It's visual then. You're watching the.
Yeah. Exactly.
Yes,
so it's visual. You bring it back to the marker band. We can show it to you again, and then you have to take your finger out. The next generation of the device has an automated cutout. You press it, you come all the way back, it cuts out. You have to unlock and then complete the implant. So there's a newer iteration coming, but honestly, it's a nice, easy speed. The markers are very clear. So.
You can also rely on blood pressure. I mean, you have blood pressure, so as soon as you see that you have blood pressure back, you know that you can slow down. To slow down, you just need to go step by step. I mean, you cannot influence the speed, but you can stop and go a little bit further, stop and go a little bit further. But it's rarely needed, as you saw in the case. He just stopped when you saw the blood pressure come up, the position was fine, and then just finish.
You saw that a couple of 2 cc injections, go a little bit further, make sure, and then you can go for a longer one.
One final
We'll do one final, and then we're going to move on.
Yeah.
I was just wondering, because you stress that it can be so precisely and nicely and highly implanted. What is the pacemaker rate actually in this?
Yeah, that's a good question. The pacemaker rate on the clinical trial from 9 years ago was, I think, 22%.
Yeah.
So yeah, but that's 9 years ago, before we had cusp overlap, before we had the understanding that we have now. For me, what do I think? Maybe you guys can answer as well. In my practice, the pacemaker rate is the same as every other self-expanding device, which is in the region of, in our hospital, about 8-10%. Marco and Ola, you have a good experience. Yeah. Dr. Liao Jianfang, you can tell us as well what your pacemaker rate is.
Less than 10%.
Less than 10%. Yeah. So I think about the same as the others, but you're absolutely right. It has more punch. There can be a cost for that in terms of pacemaker, for sure. But I think our experience is pretty similar. Huh?
If anything, I mean, you can just implant higher. So that's also a misconception from some engineers. They always thought that they need less radial forces there on that inflow. I would go against that. I mean, the fact that you have more radial force in that inflow makes it possible for me to implant systematically, repetitively, very high. So indeed, my pacemaker rate is also around 10% in my hospital, and I take even challenging cases with this device. Very often many severely calcified bicuspid cases. I mean, so these are patients not easy, and you have excellent results of PVL as well. So
no problem. So in terms of challenging cases, you need to look no further than China. Mm-hmm. So Dr. Liu, tell us about your case and your experience with this device.
All right, thank you for having me here. I'm Zhen Luo from Guangzhou, China. Actually, our city is very nearby Hong Kong, and our center last year been done about 7,000 PCI, and for TAVI about 200. This year around 300 cases for TAVI. And for the Darren permission, I just changed my topic, probably talking about some stratified high implantation with proper technique and proper device to achieve a better outcome in TAVI practice. So when we're talking about the implantation dip, I think this paper may be very important. Should be the very first one paper regarding the implantation dip. Because in this paper study, they mentioned there's a free method to assess the depth of the implantation. So it's no doubt if you just put the platform too deep is more pacemaker view implantation, and then bigger platform will be more deeper. That's what we learned from this study. And also, sometimes it's very common when we put, especially for the self-expandable platform there, it's non-coaxial implantation is very common, something like the picture shown here. There's some angle, somebody just measured that, is less than 3 degrees, or less than 4 degrees, or less than 20 degrees. Different degree probably introduce different clinical outcome. Because in this study, we can see no matter in the realized or this study. So we just figure out for the high implantation for the stem platform, I believe is very important. But sometimes it's very difficult because if you go high, we jump out, go deep, it will cause more pacemaker implantation. There's a lot of technical problems. So for some of these problems, I believe cast overlapping technique is very important. Right now, we just use that for almost every single case. So obviously, it can solve a lot of problem to make the platform too deep. So to do so, probably we need a good technique. Probably we need a very good device. So good technique, probably if you base on the cast overlapping technique, you can make the whole outcome is better. But the better device probably can do more stable deployment, no jumping or slacking, and more control, especially for the coaxial, and more predictable, and induce some more secure, good clinical outcome. So this platform, probably Darren already mentioned, everybody know about that, is the distal probably is more radial strange, and the middle part is less, and the less in the proximal part. So this design is can give us a more safe, more good outcome. For example, is very strong in the distal, can make a very good fixation, and come with a double layer screw, probably less PVL. And the middle part can combine with the distal part, can get a very good outcome when you do the high implantation. And the proximal part, probably you can see is very soft, so can conformity for the ascending aorta. So this is the device Darren already mentioned, but this just the second generation for the VitaFlow. We do have a third generation for the VitaFlow. So this one, Darren already make a very, very good demonstration just now. So here's two cases I want to share with you. The first case is a pure AR case. It's a pretty young patient, and the ejection fraction is not so good. The patient, when we come to us, got a very good shape. That's the CT analysis. We can see the whole structure is quite friendly to use off-label device for the AR. So the annulus is not so big. The LVOT is 30, looks a little bit bigger, like a flare structure. And right below the LVOT, there's a very good structure, something like a fixation point is getting a little bit narrow. So the patient is no calcification. The angle is 65. The both coronary high is quite good. So that's some more detail regarding the whole anatomy. The entry size is good. So what we did, we used the bigger size VitaFlow. Is the annulus oversize is going to be 20%. Right below the LVOT is 70%, and the ascending is 8.3%. So that's the procedure with the pre-angio. And this is the VitaFlow, second generation. The initial position is very high. We just draw back the shift and see what's going on. And the Y is lender crease. So in this point, we just keep the pushing tension for the lender crease, and then continue to deploy the whole system. During the deploying, we believe we have to push both for the wire and for the device, so we can see the whole system is opposed the outer curve more and more. So that's the deployment. That's almost finished the case. We can see here is quite a good coaxial. And finally, we just fully open the device. We can see. So when we see the angle is very, very, very small angle. So I think that's a good result. Okay, can I come back? So that's the final result. So you can see.
If you go back one more.
Go back again.
Go back?
One more.
Yeah.
And go back more. Okay. So this is the final result. So it's got quite a good result because we just appreciate the narrow structure right below the LVOT. So for this case, we can use off-label device for the pure AR. So the patient is really doing good. It's no conduction disturbance right after the procedure. That's the second case. This second case, we use the third generation of VitaFlow. Right now, it's not available in Europe, but already available in China. There's pretty old patients with significant AS and have.
Sorry, can
yes.
I interrupt you just a second? How many of you would have used a self-expanding prosthesis for that kind of AR, a 34 Medtronic? Would you rely on one courageous guy? Yeah. Because, of course, one of the nice features of this prosthesis is that even the largest valve has this more tubular shape, so it's less prone to slip down into the left ventricle. So I have no experience with the VitaFlow. So you use it routinely for your aortic regurgitation patients?
Not routinely.
Not
It
routinely.
depends on the anatomy. Yeah, because the case we did has got a very good structure. It's good for the off-label use. But not for all cases.
Yeah.
Mm-hmm.
Right now, we have a J valve available in China. Probably the other cases probably wait for the dedicated stem platform, valve platform.
Yeah. But many Chinese physicians have a good experience with this device in pure AR. They have a dedicated sizing algorithm that, as long as not only the LVOT is in sizing range, but the annulus, and also that there's something to grip on the aorta, that there's some form of oversizing of the aorta relative to the frame, then you're pretty much okay. Again, they have a publication for that in your intervention, but it's not something that's on label in Europe. It's not something that we would encourage non-expert operators like us to do, whereas you guys have a wealth of experience in treating AR with these devices. We'll move quickly on to the last case before.
Okay, sure. There's another case for AS. There's the whole CD analysis. It's maybe the common case for the daily practice. So there's some more detail. The special is for this case is we use the new generation device. That's the pre-angio. So that's the flex system. When we go to the arch, we can flex the system, something like sapien free. So,
Dr. Leo, can you just point out with the pointer where is the flex in that system?
Right here.
If you
would like to say the proximal and distal.
Just above
because
the valve.
right now this flex is the 3D flex, not the two-dimension flex.
So if you look at the capsule looks fairly long, right? If you look at the back end, the black hub in the middle is the top of the valve, and then you have 4 centimeters of flexion capsule behind that, and that allows the system to flex down at the level of the valve.
So when we push the device, let me see. Come back. You can see the right picture. The whole device draws inside the pigtail not against the aortic wall. So that's a much safe when we push all the way to the valve. Yeah, you can see that. That's a London Chris wire. We just push and flex. So we just deployed it. When we close the valve, I just flex 100% and then release back to the 60%. So that's a deployment. That's the simulation right after the procedure. We can see the 3D coaxial is very good for this case. Okay, that's the final. We do the post-dilatation because we want to get a better shape for the valve and minimize the gradient. So right after the post-dilation, we can see pretty good, no PVL, and the gradient is getting a little bit lower. So that's all. Thank you very much.
Thank you.
Thank you.
I think in the interest of time, if you have questions, hold on to them. We can bring Dr. Leo back in. But Ole, I'm going to give you the final moments. We've got 10 minutes to wrap up.
Okay.
So if you've got questions, hold on and we'll get to them after Ole shows you his case.
Then I will go very quick to the case because there's a recorded case, and it's indeed also from the VitaFlow Liberty Flex, so for the 3rd generation, the flexible one. Maybe very quick as an intro. So what is it? We have that flexible catheter there, you see, and this can be flexed really a lot. You can even flex this completely 180 degrees if you want. Normally you don't, but you have that option. There is, as Darren already said before, wait, I will better point there, I guess. Yeah, I want to go to the right. Okay, it doesn't work. On the right top, you see it's a safety knob at 75%. So if you open the valve to 75%, now you have to physically push that slot there to make it go further and expand and release the valve. The capsule has been optimized also a little bit. I'm going to try this again. Yeah, so here you see the flex again, and then the motorized handle part here for the deployment and recapture, that's exactly the same still. So where is that flex part sitting indeed? The flex part is sitting right after. This is the capsule that holds the valve, and the valve is around, as most of these self-expanding valves, they're around 4.5 to 5 centimeter long. So this stays, of course, non-flexible, but the flexible part, it feels also really nice in your hands, like a bit, like almost like a delivery system of a mitral clip, like it feels very robust and really steerable. And you see here, for example, you can then do everything to get that coaxiality right with your annulus plane. That's one of the drawbacks these days with self-expanding, I would say, that they are not steerable. And I mean, people doing mitral tricuspid cases, your whole success of your mitral tricuspid valve intervention hangs on coaxiality. We're not that crazy dependent in TAVI, but that's because we come away with it, but it's suboptimal. So, but if we have a delivery system where we can get the coaxiality right, yeah, of course, it's clear that if we can do more symmetrical implants, then we will have better outcomes, less pacemakers, etc. So, also, so in which anatomies is it useful? I would say I'll make a big discrimination between these are so-called both horizontal aorta because we simplified it that much, we simplified it too much, we just actually look to the verticality of the annulus plane. We make this measurement. On a CT, people would call this pointer is not working perfectly, but we would call it like a 70-degree horizontal aorta, for example, or the same here. But if you look to the aorta, this is a truly horizontal aorta, maybe also easier to tackle with other platforms still, but this would be extremely challenging. Such a hockey stick aorta would be terrible to treat with a self-expanding device, which is not flexible. It's not going to be easy to get a good outcome. So, very quick introduction of this case, 81-year-old male. The clinical background is not that important for the rest. Ejection fraction is 60%, high gradient. He has an RBB, by the way, with a left anterior hammer box, so a patient with a really high risk of pacemaker. And then we see here the anatomy. It's borderline between 24 or 27. But again, as Darren said, the 24 valve is actually, if you look to the inflow, it's actually 25. So if you doubt between, and the valve is also so strong on the inflow. So typically, if you doubt in a borderline zone, you stay with the smaller size, is my experience. So we went here for the 24 valve. Similar size in the LVOT. For the rest, no particularities here. You see the calcium, it's only mild to moderately calcified. So for the rest, not a very, very challenging. It's a little bit fibrotic and calcific combination of both aortic stenosis. Coronaries are fine. But what is the more challenging part on this case I wanted to show is here that we call this a horizontal aorta. It's definitely a little bit in between a true horizontal and hockey stick aorta. So we wanted to do this case with the flexible system. Here, the VitaFlow Liberty Flex, generation 3, 24 millimeter. We pre-dilated with a 21 millimeter balloon. So here we are going in with the pre-dilatation. You can tune down the audio, otherwise I can talk over it. So we do our pre-dil. And then in the meantime, I can make a small drawing while you watch the video as well. Because this, if I would have to draw this aorta, it would be, oh, that's not a nice color. Here I'm showing indeed the flex. So you see the flex you do here on the back end. This is the flex wheel that we're turning there. Yeah, the pointer is not really properly working here. Yeah, it's not working. Oops, guys. I don't know what happened here. Yeah, can you let it play again there, from there? Yes. Okay, but that's fine. Let's go in. So here, the flex, you see there on the back end of the system, we already flex it. Probably we flex it to around 80%. And that's, as Luo also said, you can keep it nicely out. You don't scrape over that aortic arch. Yes, you can keep it on the inside of the pigtail, which is outlining the outer curvature of the aorta. And then we go to our cusp overlap here. We keep our flex, and you see the challenge of this. Of course, this would have been very challenging with a non-flexible system. On the other hand, we would be bumping into that non-coronary cusp very much. But here we can keep the flex, even we probably add some additional flex. We can even go to 100% of flex, I think. Yeah, here we're trying to find a good angle here. You see how much flex we can have there in that arch. We're getting there quite a good steep angle. We try to reposition our pigtail here a bit better into the non-coronary cusp. We're struggling a bit with the interaction with the system there. And now we're going to dive into the valve. And then it's all about optimizing your coaxiality, yes? There's a lot of moving around here with the camera. Okay, good. So we go in. Yes, here we go in. Probably I'm going to ask my colleague to flex more. Yeah, there you see even a little more. I think we should flex fully, as you see here. Yes. Yes, here we're flexing completely. Yeah. Then we're going to fine-tune our angle because there's a little of parallax in our valve. You still see here, for example, I think we would max out our flex because the coaxiality is still not 100%. You see there, it's still a little bit, the trajectory of the catheter is still a little bit from the inner to the outer curvature. So probably we're going to max out the flex. Here we go. And you can really go to a full, yeah, here we show it. You can even, there's an indication there on an indicator. We are around 80–90% flex. So I think we're going to add even a little bit more flex here. And then we're starting to deploy. Yeah, now we're getting the coaxiality pretty good. So this would not be possible, I would say, with another... now we're, of course, in a cusp overlap, so you don't see the horizontality that well anymore. But having an aorta like this, now this is maybe a bit too much outspoken, but anyway, I don't know why this is so thick. It's not really nice. But the catheter, instead of arriving like this, Now we can really try to optimize, get the flex, and get the catheter more coaxial. Yes. Now we're deploying. So this we do in baby steps. You see, we even maxed out the flex there. We go in very small steps, and then we try to be as precise as possible to 1 minute, and then we go to a more faster pacing, 140, 160, and we deploy the valve. So by holding the knob. So now it's deployed. We can even go actually a little bit higher, otherwise the pressure is sometimes a little bit suppressed. But this looks good on the non-coronary side, not even that terribly high. I would say even more like a 2-3 millimeter classical. Now we swing over to an LAO view to really check on our depth on the left side. We try to find a view where there's no parallax. Yeah. Yeah, here you go. That looks fine. Even not terribly high, I would say. And then maybe you can get the audio back on from the video.
Now we go to tricuspid planar.
And you can go a little bit further. So the thing is, before we release this valve, because there's so much flex on the system, you can't see it fully, but there's a lot of flex in this catheter now. Before we actually release the valve, we take a little bit of the flex off, yes, to take all that tension off, and then we do the release, and then the valve is extremely stable. Actually doesn't move anywhere. The catheter also doesn't move anywhere. So if you jump further in the video, we can, because of the time, we have to go to the final end result. Can you do that for us? Can you jump further into the video? Can you jump further to the end?
Let me just roll the video on towards the end and see the final result.
On the flex here at the end.
Somebody can do that?
I think we're
because here we're discussing. Just go further into the video.
To maybe 40 or 30,
if somebody can do it.
That it's not overly.
Otherwise we drop it. Okay, you can do it there. All right, good. Yeah, so here the valve is released. Yeah, you can go further. Yes, here is good. Yeah, and here we have the final end result. So we're sitting really fairly high, as you can see. Yes, 1 or 2 millimeter. The valve stayed exactly where it should. And this was a patient with even pacemaker risk. You see there's still a preserved PR interval, super nice hemodynamics, as you can see. We even did IVUS to show that the valve is actually really nicely expanded. This is vascular IVUS there on the left top end. So this is now the start of the replay. So with that, I finalized the
Lovely.
case. Yeah.
So we had a question over here.
Yep.
Yes. Do you start the deployment in the final, in the predicted final position, or a little bit?
No. I start where I want to be. Like I start at 1 millimeter, and then you start opening it. Then in the initial part, you correct minimal. You go baby steps with the expansion, and then when you position it, when it's flared open 20-30%, you know, fast pacing on, you deploy to 75%.
And the final deployment slowly, or you go?
Yeah, I do slowly, slowly, and I take a bit of. We had so much flex in this particular case, 90, almost 100% flex on. Then we went almost back to 30% flex. We took a lot of the flex off for the final release.
And you can take your time. You can just go bit by bit. You can press deploy, stop, press deploy, stop. So it's very controlled.
It's very controlled.
We're just out of town, guys. So we're gonna wrap up. So I want to thank you guys for coming. I want to thank MicroPort for sponsoring the session. I think that when a new device enters a market that's mature, it needs to bring something else. Being a me too, being not inferior, doesn't really advance things for our patients. And what I hope we've shown to you today is that the MicroPort VitaFlow system does add, I think, significant benefit, significant features that can help you in your day-to-day clinical practice. So with that, thank you for coming. Thank you for your questions and your interaction. Enjoy the rest of the meeting, and we'll see you in the bar later on.